Hello and welcome to Conversations with Dr. Bachner. Once again, it is Dr. Bachner, Howard Bachner, Editor-in-Chief of JAMA. And I'm joined by two remarkably distinguished individuals. One is a good friend who I've known for many years. He's our legal correspondent, knows an incredible amount about the legal issues involving health as well as ethics. It's Larry Gostin. He's a university professor, Georgetown University's highest academic rank, confirmed by the university professor. He's the founding Linda D. and Timothy O'Neill Professor of Global Health Law. Welcome, Larry.
Thanks, Howard. It's really great to be with you.
And he's joined by Michelle Williams. Michelle is Dean of the Faculty at Harvard T.H. Chan School of Public Health, the Anglopoulos Professor in Public Health and International Development. How'd I do with that one, Michelle? I'm not so good on those names sometimes.
You did well, Howard.
Good. International Development, H.T. Chan School of Public Health, internationally acclaimed epidemiologist and public health. She's been dean for the last 4 years. We're going to talk about what will evolve into one of the greatest challenges in the history of public health in the United States, which is the lawful and ethical prioritization and distribution of vaccines with respect to racial minorities for the COVID-19 vaccines. Larry and Michelle have written a viewpoint that we're publishing simultaneously with Harold Schmidt, and it is entitled, "Is it lawful and ethical to prioritize racial minorities for COVID-19 vaccines?" We're going to start with what was the recently released National Academy of Medicine's framework for the distribution, and then we're going to talk about the content of the viewpoint. And I've already discussed with Larry and Michelle that Larry will outline the proposed framework from the National Academy of Medicine. Larry?
All right, thanks, Howard. And let me just begin by saying, we've been friends for so many years and friend of JAMA. It's just really, it's wonderful to be with you. I mean, our viewpoint really begins with the idea that racial minorities, Black Americans, Latinx, indigenous communities have disproportionately been burdened by COVID-19 and also have a long history of unequal health outcomes. The National Academies of Science, Engineering, and Medicine has recommended prioritization of racial minorities who are worse off socioeconomically and epidemiologically. And the WHO, World Health Organization, also cautioned that if we just did colorblind allocation frameworks, we could perpetuate and exacerbate racial injustice in the United States, particularly in relation to health. And so the question for us, for Michelle and I and Harold Schmidt in this viewpoint was really, what is the ethical case for prioritization of racial minorities for vaccines, and what would be lawful and constitutional? And we started, of course, with the National Academies framework. The Academies allocates vaccine in 4 sequential phases with distinct priority populations. And within each population group, vaccine access will be prioritized for geographic area identified as vulnerable by a statistical measure called the Social Vulnerability Index. That index has as one of its factors racial classifications, that is, to give some priority to race. But as Howard, Michelle, and I were talking about before we even came on to this view, the national academies are making recommendations to the CDC's Advisory Committee on Immunization Practices, but ultimately the decisions about the actual allocation of these vaccines will end up with state and local health departments, and a lot will depend upon how they allocate them. And of course, the most important thing is we don't want a free-for-all based upon wealth or power or influence. We don't want states to be bidding against one another as they did with personal protective equipment and other things in the early stages of COVID. But what we want is an ethical, legal practice so that we can ensure that the most vulnerable among us and those who have been subjected to such great disadvantage, not only with COVID-19, but before that, that they have a fair shot, an equitable shot for a future that's healthy. And that's the importance, I think, of this problem. That's what Michelle and I have tried to contribute to. And now I'll just turn it over to you, Howard, and we can begin a conversation.
Yeah, we'll return to certain issues because I think in the viewpoint you emphasize that a distribution based upon race alone could eventually make it to the Supreme Court and be found unconstitutional, and that's to be avoided. Exactly. So we'll return to that, and I just want to mention that both for the National Academy of Medicine and the Advisory Committee on Immunization Practices, they're likely to prioritize, at least initially, the 20 million or so estimated healthcare workers. And then after that, it'll be essential workers and then at-risk populations. And then there's prioritization within each of those groups. Michelle, the second section of the viewpoint is entitled COVID-19 and Communities of Color. It's been a very painful year for the United States, and particularly for Black Americans and Latinx and other groups. How do you think about this vis-a-vis vaccines?
Yeah, no, thank you, Howard. Just to add, the motivation here is to really not go back to that painful space where we were as we were appreciating just how widespread and disproportionately spreading the virus was. So it was painful because we saw an unfolding of the pandemic, and then we saw the murder of George Floyd.
Right.
And that brought into stark relief for all of us a real awareness and awakening and reckoning of the basic inequalities that exist in our society. And it was playing out during the time of a pandemic. So health disparities and access to quality health care, access to testing, the disproportionate burden of infection rates, but also death rates attributed to COVID came into very painful, stark relief. I will tell you that we were motivated in having a real discussion in the middle of our viewpoint here about the social justice rationale for the framework that we wrote about, because you had to think about, as the pandemic unfolded, we saw that lower income individuals, largely Black, Latinx, and Native individuals, were less likely to have access to testing, while they were more likely to be in occupations where the feasibility of doing the public health intervention of working remotely was not available to them. They were living in dense housing situations with multiple generations in a household. So higher risk older individuals were particularly at high risk in the Black and brown communities. The fundamental structural inequalities that existed pre-COVID just became just that much more visible and stark for us to appreciate. And when we think about what happens in allocating a vaccine, we realize that a race-based allocation model would be fraught because of the legal issues that Larry discussed. And there are social vulnerability index that race is an embedded variable within the context of other geographic, income, employment, population density variables that give us the opportunity to have equity as a cross-cutting consideration in how we allocate the vaccine, making sure the vulnerable and the high risk have access without running up against legal and ethical issues.
Larry, what would be the legal challenges? I mean, you talk about it in a viewpoint. I know this is your area of expertise. What are the potential legal challenges?
Yeah, well, we have to see this also in the context of the current confirmation hearings of Amy Coney Barrett, because the judicial composition of the Supreme Court is going to change. Already there was probably a majority, a 5-4 majority before Ruth Ginsburg died, in favor of what the court calls strict scrutiny of any prioritization, whether it be in educational benefits or in this case health or vaccine benefits. And strict scrutiny means, usually it means that you can't do it. Chief Justice Roberts famously said, if you don't want to discriminate against race, then don't discriminate against race. And that's, could be a dagger to the whole idea of affirmative action and trying to remedy past forms of discrimination. And so with the current changing composition of the court, we thought that the last thing we wanted to do was to see something so sensitive, something so important to health of the American population. As you said earlier, Howard, this is the most important allocation of a medical resource that I can remember in my lifetime. We don't want its implementation stalled or controversial as it winds its way up to the courts and the Supreme Court. And so what Michelle, Harold, and I tried to do is find a way to actually de facto give preference to racial minorities, but based upon, clear disadvantage, clear social and economic disadvantage. And that was the way that we were really nudging the CDC, ACEP, and the national academies to do so. They could accomplish the same goal, but do it without really just feeding into the cultural controversies that are going on in our country today.
Michelle, do you think the social index goes far enough? Do you think it gets us to immunization of those groups that have been so disadvantaged for such a long period of time? I mean, we're all a little older. Healthcare disparities have been with us for many, many decades. That is not the new issue. They were unmasked in kind of a painful way, obviously. And then, as you already mentioned, combined with the killings of various black individuals, men and women. Do you think the social index goes far enough in making sure that those groups appropriately get access to vaccines?
It's a great question, and I will tell you that, in our viewpoint, we indicated that we should model, in communities how it goes so that we can empirically answer your question. But I think from this perspective, we will have to do something. And the Social Vulnerability Index, there's precedent for it. It was developed for us to be able to be prepared in response, be prepared to respond to natural disasters that would hit vulnerable communities. And so it is a good place to start, given the legal context that we have that you heard Larry just talk about. It could probably go further, but we will have to do the modeling in communities, in states across this nation to really identify just how far and just how consistent it will capture the low-income Black and Brown and Native American populations that are vulnerable to this pandemic and, should have reasonable access to a vaccine that is healthy, that is safe and effective.
The good news is there's enough data to actually do the modeling. The data exists. So it's not like it's going to be theoretical and you'll have a lot of disagreements over the models. We haven't published any modeling papers over the pandemic. I'm happy because I think all of them were wrong in different ways because it evolved so quickly. Larry, what's the fine line, the legal fine line?
Yeah, well, let me begin by saying that if it were me and I were on the court, I would be much more partial to explicit racial preferences.
Okay.
I do believe in affirmative action, and I think in our viewpoint, Howard, as you know, we make the ethical case that structural racism does justify race-based classifications, but for the court, and that goes exactly to your question, Howard. For the court, anything that has a specific race preference, that is, once you actually single out race as one factor or even one of many factors, you could get strict scrutiny. Now, so if you might recall, just by analogy, the affirmative action cases that came before the court in relation to admission to universities. Right. That was very, very controversial. The court said, well, if race was just one of many characteristics, that it could accept it. But the court's shifting. It's been shifting very quickly, even before this new confirmation that we expect. And so I think that any explicit class based upon race, even if it's diluted with many other factors, could find its way to the courts. And at the moment, the Supreme Court has been quite hostile to the idea of any race-based classification at all.
If a vaccine gets approved in the first quarter of next year, let's say January, February, and they announce that 50 million doses will be available, let's set aside how will they be distributed, how will they be allocated within in the states. I think the general sense is they'll go to healthcare workers first. Now, the good news is hospitals generally are pretty good about storing vaccines and giving it. Once we go beyond healthcare workers, we have an entirely different set of challenges, just logistical challenges. Could the Supreme Court get tested quickly? I mean, usually I always have a sense it takes months or years, but could it move up to the Supreme Court by February or March? Is that actually even possible, Larry?
It's unlikely.
Okay.
It's unlikely, but it is possible. Normally, the court won't take a case unless it's been well vetted in the lower courts, and even then, it requires two Circuit Court of Appeals to be in conflict, as there are many of the Affordable Care Act and other kind of cases are just those kind of cases that the courts dealt with. But we're in uncharted territory, and already the Supreme Court has made two decisions relating to COVID-19. And they both had to do with religion, the freedom of religion. Frankly, with a 6-3 majority, that case probably would have gone the other way, because now Chief Justice Roberts is the swing vote in closely contested,
4-4,
really socially raw cases. He won't be anymore, most likely. I'm just assuming that Judge Coney Barrett will be confirmed. She's very well qualified, and so it could go up very quickly. And if it did, I couldn't say with a great deal of assurance that they wouldn't either strike it down or send it back down to the courts with clearer instructions, which delays as we say, it delays one of the most important public health implementations that we've seen in our lifetimes.
Now, Michelle, it's interesting. In the viewpoint, you talk about a different scale, and I was struck that you said that that they are different. The other one that you talk about is the Area Deprivation Index, the ADI. You don't have to go into great details, but how is that different than the one that the National Academy of Medicine mentioned? Because I know in the viewpoint, the three of you talk about it. You talk about as that being more comprehensive in trying to identify individuals who are disadvantaged, and that it speaks less specifically to race. Could you just talk about these different scales?
Right. So the area deprivation index actually integrates a number of variables. It integrates income, education, employment, and housing quality in deriving a vulnerability. And so it does not explicitly use race, but these variables are intertwined with race and ethnicity. And so you can get at the level of vulnerability, I think, without explicitly invoking race. The social vulnerability index, which was developed specifically for public health emergencies, for identifying vulnerable populations in the face of natural disasters, hurricanes, earthquakes, is based on 15 different variables. And race is among those 15 variables, but it's only one of them. And so it has allowed local, regional, and national planners to allocate preparedness and response resources based on population vulnerability that includes race, but not explicitly or exclusively due to race and ethnicity alone.
Michelle, what's your sense? So, you're dean at the Chan Harvard School of Public Health, Harvard Chan School of Public Health. Sandro Galeo, who writes for us, is at BU. Dari Mozafarian, a former faculty member for you, is at Tufts. So the governor's going to call the three of you up, and he's going to say, we have 10 million doses for the Commonwealth of Massachusetts. What do you do next? Let's take the healthcare workers off the table. That, 1 million doses went to healthcare workers. You have 9 million doses left to distribute. And he calls up the three deans of the schools of public health and says, help me. What's your sense of what you would do next, Michelle?
My guiding principle would be that equity is a cross-cutting, really central to the decision-making of the distribution of the vaccine. I would definitely say if we've got healthcare workers covered, then we really have to think about essential workers, right. And we have to do that through and vulnerable elderly population, particularly those living in crowded settings and with high risk medical conditions. But all of that has to be undergirded with a strong commitment where equity is core at the consideration.
Larry, can this vary a great deal from state to state? We talked earlier, it is confusing. McKesson's going to get 100 million doses and they'll distribute it to the 50 states, Puerto Rico, District of Columbia. I mean, it was a nightmare with remdesivir. I remember one critical care doc saying, we just got 100 doses. I have no idea why we got 100 doses. We have no cases. Meanwhile, Michigan they didn't get enough remdesivir and they had cases. Assuming we're a little smarter at it this time, could what the Commonwealth of Massachusetts do be very different than what Alabama does?
Yeah, I think it will, obviously, because no matter what framework is used, Howard, it's absolutely going to be up to state and local health departments and ultimately to state governors and legislators to make the decision about how exactly things are going to be implemented. This is also another legal question as well as a policy and public health question, because we're a federalist society. The Centers for Disease Control and Prevention don't have any power, right, to force states to do anything. It can give them the resources, but then it can't go in and micromanage what exactly how they're allocating. And it's very possible that you could have, a highly conservative, say, southern state that might make very, very different choices than a state like, Massachusetts or New York or Maryland or the District of Columbia. So yes, you're going to get really, really different outcomes, and that's, federalism has been a conundrum with COVID-19 because it's supposed to work well by giving states kind of, they're closer to the people, they're more innovative. But in the end, it hasn't been uniform. There hasn't been a national plan, and that's been a problem. So I hope that problem won't continue.
Yeah. I've had a lot of discussions with the Advisory Committee on Immunization Practices just to try to understand. It is just an advisory committee. It's very striking. I mean, I'm a pediatrician, so we follow what the American Academy of Pediatrics says all the time. But the ACIP is an advisory body. It has no legal standing at the state level. Do you two fear that money will win out? I always feel like I'm amazed who was able to get tested. I'm still amazed at like the hockey league, the NFL, the NBA. They seem to have as many tests as they want. I'm amazed. Do you fear that money will win out, and in the end, of the available 10 million doses, really well-off people will just pay for it and get it?
Both Michelle and I are clamoring for this. You can have the first go, Michelle.
No, absolutely. I mean, I think one of the most disheartening things at the outset of this was the access to testing really depended on whether you had resources or you were a celebrity. And the people who needed testing the most were, essentially an afterthought. The essential workers who had high risks commuting to their work, high risks at their work, high risks in their house, multi-generational households, were often an afterthought in the standing up and allocating testing resources to the population. When you think about Navajo Nation was one of the last places where we really mobilized resources to get testing done. So I'm passionate about not repeating this inequity in access for the vaccine, which is going to be the single most important public health response to this crisis in 100 years. That we not make it be so blatantly, personality and money oriented for getting in the front of the line.
Yeah, Howard, would you mind if I jumped in here as well?
No, it's meant to be a conversation. That's what it's called.
I obviously I totally agree with Michelle. I think this is what's going to happen. It won't be the same kind of raw inequity and free for all based upon money, power, influence that we saw with testing and personal protective equipment and things like that. Because I think we will have a national plan, we will have national priorities, and that's good. So I think it will take the edge off of the raw, power-based, money-based competition. But I can't imagine that having a considerable wealth, access to concierge or well-paid physicians, and also power, including political power and celebrity fame, won't push you closer to the top of the queue. It's very hard for me to see that the case. If you think back to the H1N1 vaccine, this is now taking it globally, there were pre-agreed with WHO distributions based upon a more equitable formula for lower income countries. But once the epidemic hit, everybody pulled out, all the high income countries, including President Obama. And it was only when we had enough vaccine that it was then distributed. And I think we're going to see not as raw as before, but we are going to see class and power and money race preferences. It's hard for me to think otherwise.
Michelle,
Howard, if I may, there's one other consideration, and that is the infrastructure available for distributing, disseminating the vaccine is going to be important. And so, when we talk about communities, when we talk about states, it's going to, in large part, be how ready are the systems, the public health systems, the healthcare delivery system, to manage implementing the distribution of the vaccine. And that's something I worry about as a public health person, where there's been, prolonged underinvestment in our infrastructure.
Yeah, and of course you've got, getting it to kind of poorer rural communities, inner city communities, things like that. I think that the less prepared we are in terms of our vaccine and healthcare infrastructure, the more we're going to see discrimination against the poor, because those are the ones that often have the most difficulty getting access to medical resources.
Well, as I said, if the first 20 million doses go to healthcare workers, the good news is that they're largely hospital-based, and hospitals will be generally good at storage and distribution. I thought there's 10,000 community health centers in this country, and they really do serve a very specific population described in these social indexes. And I was hoping that we could sort out a way to make sure they know how to store and distribute vaccine, because then I feel like they're connected to the community that we would like to focus on. And so I'm hoping that each state will be able to invest in those community health centers that they know serve the group of people that these indexes are going to model and say should be a priority. And many of the people who are essential workers probably get care at those community health centers. I know I'm biased. I'm thinking of Boston, of East Boston, Dorchester House, where I know Chelsea. Those are the places that would be able to reach the individuals. Two questions have come in. It's the same question. Michelle, I feel like I have to ask you. You're African American. The issue of vaccines in the African American community. How do we get there? How can we try to get to more trust around this issue?
That's a great question. We've got to work on this, and I think it begins with acknowledging and reckoning with our history that really contributed to an erosion of trust. This is not the first time that the African American population has been skeptical in the face of public health crises. We have to really get to a place where we reckon with the past wrongs and we effectively communicate to this community. It means investing in holding intimate conversations in communities around where we've gone wrong and why we have to move past, let's say, Tuskegee, and think seriously about how African Americans engage in participating in clinical trials. The efficacy and safety of the vaccines will only be generalizable to those populations who participate in the trials, for where we can accrue the experience and the understanding of safety and efficacy. So there has to be clear conversations, reckoning with the past, and then an acknowledgement of the scientific process that involves recruitment of a diverse population of individuals by geography, race, ethnicity, age, in these clinical trials, so that when we are out of a phase 3 clinical trial, we know the populations to which the inferences about safety and efficacy can be made. We have to go upstream, Howard, honestly. We can't just go to Black and brown communities and say, sign up for clinical trials, participate in clinical trials, if there is not deep representation upstream in the science and the management of the processes that bring about the science. So it means really finally reckoning with the systematic racism, the history of where Black and brown people have been misserved, excluded from the research process, excluded from the data that brings forth information about safety of therapeutics and vaccines, and then a real effort, as we've discussed, to make sure that we don't do anything in the allocation of safe and effective vaccines that would exacerbate disparities.
Larry, final word?
Yeah, I mean, Michelle said it so eloquently. We have I was going to say a deficit of trust in the United States, but it's really a cavernous distrust, a huge gap. And we're going to need to do a lot as a scientific, medical, public health community to actually work together to make sure, as Michelle said, both upstream and downstream. I think we're going to need to go into communities, have community leaders lead vaccine trust and trust in public health. But we're also going to need government to actually go back to the way that the data that we've got, the research that we've got, and really kind of make up for a long history where frankly public health deserves that distrust unless we earn it back, and we need to start earning it back soon and urgently.
This is Howard Bachner, editor-in-chief of JAMA. This has been Conversations with Dr. Bachner. What a pleasure to talk with Larry Gostin. Larry is our legal correspondent. He's a university professor at Georgetown, Georgetown University's highest academic rank. And Michelle Williams. Michelle is Dean of the Faculty at the Harvard T.H. Chan School of Public Health, internationally recognized epidemiologist. We've been talking about an incredibly important viewpoint. Is it lawful and ethical to prioritize racial minorities for COVID-19 vaccines? Harold Schmidt is the first author, and Larry and Michelle are his two co-authors. Larry and Michelle, thanks so much for joining me today, and please stay healthy.
Thanks, Howard.
Take care.
Okay.